Welcome to LRD-USA and our Management of Partial Foot Amputations online continuing education program. We hope that during the next hour or so, you will find information that will make your job easier and will help you optimize the outcomes of your partial foot patients. We'll start with a quick overview of partial foot amputations and then look at the consequences of amputation. In managing the partial foot amputation patient, we'll look at different aspects of both preserving the residual limb and restoring gait function. Fabrication techniques are then reviewed, and that will be followed by gait training and by outcomes that we've seen using these techniques. Finally, we'll look at coding considerations that may be useful to you in billing for the work that you've done. The most recent data indicate there are about 67,000 toe amputations and over 18,000 partial foot amputations per year. The vast majority of those amputations occur in patients between the ages of 45 and 84 years old. This map shows the diabetic population distribution within the U.S., with the dark blue indicating over 10% of the population having the diagnosis of diabetes. More recent data show that over 25% of the U.S. population aged 65 and older have been diagnosed with diabetes. Some data suggest that the incidence of partial foot amputations seems to be increasing, while the incidence of transtibial amputation is proportionately decreasing. Diabetes is the leading cause of partial foot amputations. While partial foot amputations occur at an incidence of 3.8 per 100,000 population without diabetes, 2 per 100,000 population with diabetes. This is one reason the CDC refers to both obesity and diabetes in the U.S. as epidemics, which in turn may explain the increase in partial foot amputations. Nearly 50% of diabetics suffer from peripheral neuropathy, which can lead to painless trauma. Because there's no pain associated with the trauma, it often goes undetected, and that can lead to infection and ulceration. 85% of amputations are preceded by an ulcer. There is nearly a 25% incidence of some level of arterial insufficiency in the diabetic population, and that can lead to cell death, leading to the onset of gangrene. The only known option to manage gangrene is amputation at the level where the tissue is still viable. The pediatric partial foot amputation population is relatively small, but if you work in a tertiary pediatric center, you may end up managing quite a few of these patients. About 60% of pediatric partial foot amputations are congenital. About 40% of the pediatric partial foot population is secondary to trauma. Motor vehicle accidents and lawnmower accidents lead that trauma list. The levels of partial foot amputations are fairly straightforward. A toe amputation is usually a disarticulation at the DIP or PIP joint lines. A toe disarticulation is an amputation at the MPT joint line, which leaves the metatarsal heads intact. A transmetatarsal amputation is exactly what it says and is one of the most common partial foot amputations. It's also the one that poses the greatest challenge with respect to managing the resultant shearing forces. We'll discuss that later in the program. A Lisfranc amputation is a disarticulation at the Lisfranc line of joints. And finally, a Chopard amputation is a disarticulation at the Chopard line, leaving just the calcaneus and talus. In her 2010 edition of Gait Analysis, Jacqueline Perry describes propulsion as one of the 4 key components of gait. In fact, between these 4 components, she lists propulsion as first. Without propulsion, there is no locomotion. In the normal situation, calf muscles contract to send power through the Achilles into the calcaneus to plantar flex the ankle. This power activates the propulsive lever arm of the foot to propel the foot off the floor and at the same time to initiate swing to advance the limb through space. A biomechanical balance exists between the power of the calf group and the length of the propulsive lever arm of the foot. When there's a lack of power crossing the ankle, the resulting condition is referred to as apropulsive gait. There are three broad categories of medical diagnoses that can result in apropulsive gait. The first is neuromuscular dysfunction of the calf group that is commonly seen with a diagnosis such as CVA. If the calf group isn't functional, the patient can't propel the foot off the floor. The second broad category is associated with soft tissue dysfunctions such as Achilles tendonitis or tendinopathy. Posterior tib tendon dysfunction and plantar fasciitis also fit into this category, where power crossing the ankle is limited or restricted by pain. This leads to compensatory mechanisms during gait that are very similar to those caused by a CVA. The third broad category of apropulsive gait is the loss of the propulsive lever arm secondary to a partial foot amputation. If the propulsive lever arm has been amputated, it doesn't matter how the calf group functions because it still can't power the foot off the floor or initiate swing without that lever arm. This also leads to predictable compensatory mechanisms during gait. With a lack of power crossing the ankle, compensatory mechanisms are needed to pick the foot up off the floor and to initiate swing. These predictable mechanisms include, but are not limited to, trunk lean to assist with hip hiking to pick the foot up off the floor, and trunk torque to advance the pelvis in order to initiate swing. A shorter sound side step length to make the compensatory mechanisms easier, and a shorter involved side time in single limb stance because that limb's not stable or propulsive. Because of the compensation mechanisms, the metabolic cost of gait increases as ADL distance capacity decreases. Physically fit patients may mask some of these mechanisms for a while, but all will appear over time. We will discuss minimizing these compensations later in the program. In addition to loss of propulsion secondary to partial foot amputation, there is also an equally predictable loss of limb length as measured from fibular head to floor. The next few slides will show the anticipated loss of limb length associated with each level of amputation. Starting at baseline with the ankle at its neutral 90 degrees, the neutral sagittal plane calcaneal angle is about 40 degrees. This becomes an important reference to assess ankle posture relative to different levels of amputation. The goal is to restore ankle neutral postoperatively as soon as possible to avoid the formation of an ankle plantarflexion contracture. The shaded foot outline will appear in the following slides in the exact position as you see it now, so changes to the foot from normal can be referenced at each level of amputation. There should be no loss of limb length associated with either a toe amputation or a toe disarticulation. The primary distal support structures are the metatarsal heads, and as long as they're still intact, there shouldn't be any limb length loss. With a TMA, the metatarsal heads are gone and the ankle has lost part of its distal support structure. There's a predictable 3/8 of an inch to 1/2 inch limb length loss associated with this level of amputation. Note the calcaneal angle is no longer 40 degrees, but has dropped down into the 30-degree ballpark. Notice also the beginning of the appearance of a slight bulbous heel at this level. At the Lisfranc disarticulation level, there's a small progression towards additional limb length loss. 1/2 of an inch to 5/8 of an inch is relatively predictable at this level, and the progression of a bulbous heel continues. At Chopart level, there's a significant jump in the amount of limb length loss. The range for Chopart is between 7/8 of an inch and 1 inch and 3/8. The other significant issue with Chopart is the posterior posture of the calcaneus. This acquired bulbous heel deformity is secondary to the ankle being at or close to terminal plantar flexion. Correcting the calcaneal angle resolves the bulbous heel deformity and helps restore the limb back to its original length. Now that we've seen the challenges imposed by partial foot amputations, it's time to discuss interventions that will help preserve the limb by managing friction, pressure, and shearing, and interventions that will help restore gait function by restoring limb length and propulsion. Friction in this application is defined as the material rubbing against the surface of the skin. Friction usually leads to blisters and skin breakdown. Make sure the shoe is sized correctly so that the residual foot moves with the shoe and doesn't rub on the inside of the shoe. The fabrication of a socket is discussed later in this program. Make sure the socket is sized correctly so that the residual foot doesn't slide around inside that socket, resulting in friction that can cause skin breakdown. To help manage pressure, make sure the shoe isn't sized too small so that it isn't putting constant pressure on the residual foot. If the socket itself is too small, resulting constant pressure can lead to tissue breakdown. It's important to check for changes in volume for the first few months to make sure the socket still fits. If a firm material is used to fabricate the filler prostheses, it is recommended that a softer durometer breakpoint be added to avoid the filler prostheses pressing into the socket during the third and fourth rockers. This step can be avoided by using a material for the filler prostheses that is soft enough to flex, but firm enough to support the shoe and keep it from collapsing. Shearing forces are the most destructive force to the partial foot, and they're also the most difficult to manage. As opposed to friction that impacts the surface of the skin, shearing is caused by bone moving on the inside of the skin, leading to disruption of those connective tissues. Shearing is the force that leads to callus formation, and that can lead to increased pressure or ulcer formation. The foot is normally functionally balanced in that the forces of the larger posterior muscle group cross the ankle to control the longer anterior lever arm, while the forces of the smaller anterior muscle group cross the ankle to control a shorter posterior lever arm. With the loss of the length of the anterior lever arm, the posterior muscle group overpowers the now shorter anterior lever arm, thereby creating shearing forces at the distal end of the residuum. If there are calluses seen on the distal residuum, then shearing forces are not being managed and the foot is at risk for further breakdown or the potential for further amputation. Filler prostheses are commonly used in the management of partial foot amputations. While appropriate and necessary to fill in the shoe, they do not function to minimize shearing forces. If a filler prosthesis is all that is used, the foot is at risk for further breakdown. The next step to manage shearing forces is the use of a carbon fiber foot plate. While these can disperse some of the shearing forces, they generally bend at the point of pressure and do not direct forces in any particular direction. Because of this, destructive shearing forces are still present and are only being partially managed. This is evidenced by the fact that most feet managed with this technique still acquire calluses. Some practitioners have even suggested that the calluses are worse using this method. There are no firm data that we're aware of. The Allard technique is to modify the foot plate to direct forces towards the shoe brake. By adding the additional lever arms of a lateral strut and an anterior shell to the foot plate, we have now effectively lengthened the anterior lever arm and have recreated functional balance. Shearing forces are now being managed and the foot is being protected from those forces. On an initial trial, we obtained plantar pressure maps on a TMA with a carbon fiber foot plate, a gauntlet-style AFO with dorsal-assist joints, and with a blue rocker. Note the short progression line in the first two images and the much longer progression line in the blue rocker image. The pressure seen at the level of the distal residual foot on the first two images is destructive forces, while that destructive force is now distal to the residual foot with the use of the blue rocker. By managing friction, pressure, and shearing forces, we help patients overcome the destructive forces that occur in partial foot amputations that can lead to secondary proximal amputations. Now that limb preservation issues have been addressed, we can move on to restoring the function of gait. The first of these issues is addressing limb length loss that was acquired due to the partial foot amputation. There was discussion earlier about ankle neutral and the calcaneal angle in the sagittal plane. From the anatomical neutral position, we should have about 20 degrees of ankle dorsiflexion and 40 to 50 degrees of ankle planiflexion, or a nominal 1/3 to 2/3 ratio. As a reminder, the calcaneal angle at the neutral posture is about 40 degrees in the sagittal plane. With a loss of forefoot structure as a reference, this calcaneal angle becomes a primary means of determining ankle neutral. This is an example of how limb length loss correlates to the appearance of a bulbous heel. Note that the calcaneal angle drops from 37 to 24 to 0 degrees. Associated with that is the change in the posterior profile from neutral to a minor change to a significant deformity. Finally, correlate that to the acquired limb length loss from neutral to a relatively small 3/8 of an inch to a significant 1 1/4 inch limb length loss. A wedge or post will be required to help restore limb length and resolve the deformity. This shows a temporary trial prosthesis on a Chopard amputee where an 1 1/4 inch wedge was used to help restore the calcaneal angle back closer to 40 degrees and to return the ankle back closer to its neutral posture. Now that limb length has been covered, a discussion on propulsion or apropulsive gait is in order. After that section, the program will cover fabrication of the device that will help resolve limb preservation issues and help overcome propulsion and limb length challenges. This is a list of attributes that are components of normal gait. Missing any one of these attributes would have a negative impact on gait. And as noted earlier, propulsion is a key component of gait and absolutely necessary for locomotion. The TOA family of products are laid up in a unique combination of fiberglass, carbon fiber, and Kevlar. In addition to picking up the foot during swing, they also help restore the function of the calf group by loading potential energy in the second and third rockers, and then reflecting or returning that energy in the fourth rocker to help restore propulsion. The concept for these devices simply mimics the function of a swimming pool diving board. Once a person loads potential energy into the board by jumping on it, the board has no choice but to spring back or return that kinetic energy. All of these LR devices share the same basic features. An open calcaneus to allow for the function of normal biomechanics during gait, thereby facilitating better proximal stability. The footplate is designed as a springboard that functions much like the foot. Motion and the dynamic response is focused where the med heads align to the footplate to mimic the function of a propulsive foot. A lateral strut acts like a spring and is positioned so that during pronation the foot rolls away from the lateral strut instead of rolling into a medial strut. Finally, a broad pretibial shell is used to offer the widest possible contact area to protect soft tissue from undue pressure. The TOA family of products are designed to bring just the right amount of support to match the functional deficits of a wide variety of patients. The Ypsilon Flow offers the least amount of support for patients who would benefit from less control, while the Blue Rocker on the other end of the spectrum offers maximum support for patients who present with significant functional deficits during gait. This chart shows the relative function of each product in different categories. The Ypsilon Flow, for example, is shown to provide a lot of motion, while the Blue Rocker will allow less range of motion. The Blue Rocker generally has the most push-off assist, so it is the most common device selected for partial foot applications. That being said, there can be significant differences in the functional capacity from patient to patient. It's usually worthwhile checking gait in 2 or more of these devices to assure the patient is getting the right amount of dynamic response to match their functional needs. The Ypsilon Flow is the most flexible in the Allard family of carbon composite devices. While generally used in light-duty applications, this device can be the ideal solution for some small-frame patients with low BMI. The Ypsilon is another relatively flexible device that is typically used for mild foot drop and for some soft tissue dysfunction applications like plantar fasciitis. The toe-off is the original product in this group and serves to improve a large array of gait deficit patients. It may be another potential solution for the partial foot patient who is thin-framed and has a low BMI. Assess the patient in various devices to see which dynamic response is best suited to each patient. The Blue Rocker is the go-to device for many partial foot patients, especially those with TMA or shoulder amputations who are a little higher on the BMI scale. The stability of the Blue Rocker is well suited to handle the stress of the partial foot amputation in conjunction with the extra gravitational forces crossing the device. This section covers the basics of fabricating partial foot prostheses as described in this program. Allowing your fabricator to see this program may help in understanding the concepts you would like to implement. To help restore lost limb length and ankle posture as close to neutral as possible, determine maximum range of motion towards dorsiflexion. It is strongly recommended that this be accomplished by having the patient stand on the end of a 1x4 board and the practitioner pick up the other end of the board to determine the available amount of closed chain ankle dorsiflexion. Assuming a 40-degree calcaneal angle can be achieved, the socket would be posted at that posture. If the ankle is in plantar flexion contracture, post the socket just short of the maximum angle of available dorsiflexion. Once a negative is obtained, a positive can be made and the socket is fabricated on that model. Practitioners have had success using 1/8 inch 25 durometer impression puff as the interface material for the socket. Because shear forces are now being managed by the composite lever arms, there's no need for a silicone interface. Then the actual socket is fabricated using 1/8 inch black copoly. The socket helps contain the residual foot to minimize the splaying of the foot. It also serves as a base to which posting or wedging is applied to help restore limb length. The anterior aspect of the socket is posted to the functional angle. Some heel lift may be included in the posting to account for loss of limb length because of the limitation into dorsiflexion. The posterior aspect of the socket functions as a biomechanical foot orthotic, allowing the calcaneus to function through neutral in the frontal plane. The anterior aspect of the socket should capture the anterior aspect of the residual foot to create a starting point from which the prosthetic foot can be fabricated. The socket is now positioned on the toe-off but will not be affixed until alignment can be made to the patient's tibia. This initial positioning helps with alignment to the lateral strut and shaping the filler prostheses. The filler prostheses is then fabricated, matching as closely as possible to the length, width, and sagittal plane profile of the contralateral foot. The filler prosthesis is generally fabricated using 25 durometer, 1 inch thick microcell puff light. This material is firm enough to fill up the shoe, but flexible enough to flex in the third rocker. 1 inch is preferred because 1/4 inch microcell puff light, as shown, will generally end up too stiff because of the number of laminations. The laminations are then shaped to match the shape of the contralateral foot. Once this is accomplished, the prosthesis is affixed to the Blue Rocker footplate with final alignment based on equal pressure distribution of the anterior shell to the tibial crest. In conditions of very high stress, it may be appropriate to reinforce the junction between the lateral strut and the footplate. Conform a high durometer material onto the plantar aspect of the footplate and taper that towards the heel and into the toe. This provides some bottom-up support for that junction. There are other customization criteria that can have a significant impact on both gait outcomes and on product durability. Please refer to the Allard Toe-Off Customization Guide for additional fitting and alignment information. O&P practitioners don't do and don't get paid to do gait training. It is within the scope of practice of O&P, however, to acclimate the patient to their new device. To start that process, ask the patient to squat by slightly bending their knees, keeping their trunk relatively upright, and keeping their heels on the ground. Once they do that in the sagittal plane, ask them to not move their feet, but to rotate their trunk one way, and then rotate the trunk to the other direction. One set of 10 in each direction is recommended. Next, have your patients do a series of lunges. Start with stepping to the side, leading with the involved side, making sure both knees are bent. Then repeat the process with stepping straight ahead. And a third time with crossover steps. These maneuvers will help them adapt to walking straight ahead and with turning left and right. Repeat the process, leading with the sound side. Patient safety is always one of the primary concerns in modifying how a person walks. Train patients how to navigate up and down stairways and ramps using standard prosthetic protocols of leading with the sound side to go up and with the involved side to go down. Most of the movements used to acclimate the patient to the device are conscious motor motions. Once the patient is accomplished in these basic movements, they should be referred to PT for gait training. The goal in gait training is to progress the patient from conscious motor movements to subcortical gait. A whole series of distractions and variations are used to get the conscious mind out of gait. Once gait becomes more subcortical, adding difficulty through retro-walking will help make forward overground gait more stable. It may be a good idea to share this program with physical therapists so they understand the big picture and understand your role and what their role should be. This section deals with outcomes. The video in the next slide is of a patient with a show part amputation in her traditionally designed partial foot prosthesis. It is a custom molded gauntlet style AFO with a leather cover and a carbon fiber footplate and a filler prosthesis. Notice not only the asymmetries in her gait and the work that she puts into it, but notice also how rigid her trunk is as she walks. Walking for her is not fun or safe or productive. The same patient then received the device as described in this program. It is a blue rocker with a socket and a filler prosthesis. She had some plantarflexion contracture, so the calcaneal angle is not quite back to neutral. Notice not only the improvement in gait symmetry, but also how freely her trunk is going along for a ride on top of her pelvis. In her book Gait Analysis, Jacqueline Perry describes that as being functionally stable gait. Now, regarding getting paid for your knowledge and your skill in restoring gait to these partial foot patients, Allard is not in the reimbursement consulting business, and we do not recommend any codes. We can't get pre-approval for codes that are discussed in this program. As always, the practitioner providing the service to the patient is solely responsible for coding that is selected for any device. That all being said, practitioners have almost unanimously indicated to us that they are comfortable with the following codes and have used them successfully for many years. There are published data to suggest that a tibial tubercle height device is medically necessary to help restore the propulsive lever arm and to reduce the incidence of shearing and ulcer formation. Do not build the device as an AFO. Reimbursement for this component is included in the base code. Due to the rigid nature of the pretibial shell, it is medically necessary to protect the soft tissue surrounding the tibia and lower leg by padding the shell. Finally, a distal cushion or socket is necessary to protect and control the residuum, to control the biomechanics of the rear foot, and to serve as a fixation point to add wedging or posting to help restore limb length. Opinions vary widely in the use of any other code or codes. Our position is that significant caution should be exercised in using additional codes. Medical necessity should be thoroughly documented and validated by the referral physician before additional codes are used. And that brings us to the summary page of this program. We've covered a lot of material. If you have any questions or concerns whatsoever about anything in the content of this program, please do not hesitate to contact Allard USA. We would love to hear from you. Thank you again for taking the Allard online partial foot amputation course. If this course has met and perhaps even exceeded your expectations, please don't hesitate to share the link with your colleagues. Thank you.